Hello, everybody. My name is Dr. Matthew Shem. I work at the Functional Neurology Center here in Minnetonka, Minnesota. And today we are going to be starting our Technologies in TBI mini-series, where we're going to be releasing different videos over the course of this week on different subjects. And today, what I have the privilege of talking to you about is diagnostic equipment that we use here in the office. And so whenever you come to the office, your first day is pretty much spent one-on-one with the doctor that you'll be working with all week here at the office. And that first day is really all about getting to know who you are, why you're here. We'll run a number of different diagnostic equipment and do the initial exam, and then sit down and try and write up a treatment plan that is catered specifically to you and your needs to best try and get you better. And what my presentation is today is about one small piece of that very first day, and that's going to be talking about most of the diagnostic technology that we use in the office. So I hope you enjoy it. This might be a long one, so buckle up. And if you have any questions, just drop them below and I'll try to get to them as soon as I can. So the first piece of technology that we're going to be talking about is VNG, or video nystagmography. And this is one of my preferred pieces of technology in the office, or I really like it because it makes patient education so easy. And I'm a big advocate for patient education because I think that when patients understand, or have a better understanding at least, of why it is that they're dealing with the symptoms that they're having and why we want to implement the different therapies that we are doing, it makes for so much more buy-in, and patients are so much more invested in the care that they receive throughout the week. And for the purpose of this talk, we're going to keep it very superficial and just kind of touch base on all the different tests that we're running in the VNG. And then later this week, I'm going to hop back on here and dive a little bit deeper and talk about oculomotor function and basically go through all the different types of eye movements that we're looking at and what they really mean. But for today, let's keep it kind of superficial and light, because it's going to be, we're going to go through a number of tests. So I don't want to dive too deep in the very first one. So the first one is spontaneous nystagmus. And basically what this test is you're sitting with these goggles on. You're sitting about, 2 arms lengths from the television screen. And what we're going to do is basically graph out your eye movements, and we're going to record what your eyes look like when we proceed through various tests. And the first one is called spontaneous nystagmus. Spontaneous nystagmus is whenever we put a cover over the goggles, so you're basically in the dark, you have nothing to visually fixate on, and we look and see what happens. Ideally, what should happen is there should be no movement, and your eyes should just stay rock solid and not move anywhere. Now, we do allow for a little bit of movement, but what we see a lot of times in the office is what's called nystagmus, or where the eyes drift one way and then beat quickly back to the other. Or what we see is what we call micro or macrosaccadic oscillations, where we actually see quick jerks back and forth like this. And these are all telling us, based on what we see, different areas of your brain that might not be working right. And then whenever we go through more tests, we're able to localize that area of dysfunction a little bit better. So towards the end of the spontaneous nystagmus test, there'll be a light that pops up in the goggles, and we'll see how your pupils react to light. And then from there, we can progress to gaze stability, or so for gaze stability, we'll pop the cover off and you'll be able to see the TV screen again. And we'll progress through a series of dots. That's one right in front of you, one left, right, up, and down. And basically just look for your ability to hold gaze or hold your vision steady on a single dot. And what we see a lot of times is patients have a really difficult time doing that. And the reason that we look at all this stuff is because eye movements are so vast, and machinery involved with actually moving the eyes and holding the eyes steady and moving the eyes quickly or accurately the machinery is so vast in the brain that whenever we see different little things, we can localize the area of dysfunction a lot better. And so with gaze stability, we're just looking at your ability to hold your gaze on a single target. And sometimes we'll see where you'll hold your eyes out here to the left, then they'll drift slowly back to the middle and then poof, back left. So you'll see a quick jerk, and that's what we call in-gaze nystagmus. Or what we could see is you have square wave jerks, where you're just kind of jerking back and forth over the target. And we could then progress to pursuits, which is basically just a dot that moves left and right, back and forth. And this is basically a gaze stability test, but in motion. And so a lot of times patients have a really hard time with this, and their pursuits end up either looking like where they're following on it and then their eyes fall behind the target and then beat back, or maybe they're following it and they get a jerk ahead and then jerk back. Or what we could see is whenever you're pursuing over towards the right, you have a right eye that comes up. And then whenever you go to the left, your eyes level out. So it's all these little bitty things. And I hope you're starting to be able to understand or get a little grasp of why it's so important and all the various little things that we're looking at. And so then during pursuits, we're basically looking at your ability to follow a target really smoothly back and forth. And a lot of patients struggle with this because they struggle with gaze stability. And pursuits are pretty much just a gaze stability in motion. And so then from there, we'll progress to Sakaz, which is basically a random dot that pops up left and right in different locations, and then up and down in different locations. And what we're looking for is how quick are your eyes moving from left to right? How long does it take to initiate moving your eyes from target A to target B? How accurate are your eyes? Are they moving whenever they go to target B? Are they hitting right on? Or are they stopping short and then having to catch up? Or are they overshooting and then have to come back? And a lot of times we can see this play into symptoms such as fatigue, where imagine this, where if you have throughout your day, you have fuel allocated to your activities of daily life. And let's say, for example, you have 5 gallons of fuel to use in any given day. And ideally, your brain would prefer to only use one of that gallon or one gallon of that 5 gallons towards moving your eyes about. And whenever you have eye movements that are inaccurate, let's say, is whenever I now shoot here and then here instead of just right on the target, or maybe I overshoot and have to shoot back, you're doing twice as many eye movements as required, and then you eat up through that allocated fuel a lot quicker, and then you have less fuel to utilize towards your other activities. And whenever you do that, then you tire out really quickly, and we see a lot of people there that get tired earlier in the day after concussion and things like that. And then we progress to optokinetic testing, or OPK testing. And basically what that is we'll put a series of dots along a TV screen and we'll just move it left, right, up, and down. And so it basically mimics a full field or full visual environment rotation, where if I rotate to the right, my visual environment is going to go to the left, and vice versa. If I go to the left, my visual environment is going to go to the right. And so we can mimic this whenever we put you in OPK testing. And a lot of times, at least lately, what I've seen is patients have they have a good reflex. They have a good optokinetic reflex, but what happens is they get symptomatic, or they get dizzy, or they get lightheaded, or they feel kind of rocky or floaty after. And what I can contribute that to is if you're sitting in front of me and you move to my left, how does my brain know that you moved to my left versus me moving to my right? So how it figures that out is if I have my visual environment move to my left and my brain says, well, I know I didn't move, I'm not getting any feedback from my muscle saying I moved to the right. So it had to have been the environment moving to the left. Or let's take the other example. If I see my visual environment move to the left and my brain says, well, I'm getting feedback from my vestibular organs and my proprioceptive system saying I actually moved to my right, then I can say the odds are probably better that my visual environment didn't move, but it was me. And so whenever you have these different sensory mismatches, or like people don't really know where their body is, and then they have a slip in their visual environment, or the world goes around them, they have nothing to compare against. So they just get really dizzy, they get lightheaded, they get rocky, things like that. And then what we can also use the VNG for is positional testing. So let's say, for example, you have BPPV, or benign paroxysmal positional vertigo, where every time I go to look up and grab that liquor off the top shelf, or whenever I roll over in bed, or whenever I lay down in bed, I get this sense of spinning. So what we can do is put these goggles on, put the cover on the goggles, and then take you through those various positions that cause you to get dizzy. And we can see different torsion of the eyes and how they jerk, and it can help localize the maneuver that we want to go into next to help solve that issue. So then just a few little points on what we're actually looking for whenever we're watching the eyes, and we'll go into this more later in the week. But one important one is alignment, and saying, if you think about both of your eyes like two cameras, ideally for you to experience clear, crisp vision and be able to take in the beautiful scene around you, both of those cameras have to be looking at the same exact target at the same exact time. What we see oftentimes in concussion is that one of those eyes will be looking off in a different direction. Either one, it'll be in or out or up or down. And all it takes is 2 degrees for one eye to be off in a different direction for you to have a visual acuity drop by 50%, and for you to experience double vision. And then anything under 2 degrees, but not quite spot on, you can experience what's called blurry vision, or you can have blurry vision. And so then we're also looking at how quick do your eyes move, how accurate are your eyes whenever they go from target to target, and how long does it take for you to initiate going from target A to B. So those are just a few of the little things that we're looking at on the VNG, and I hope that gives you a little bit better of understanding of what it is that we're actually looking for and the importance behind graphing out the eyes and looking and seeing what they do and the importance of this technology. So from there, we'll progress onto the D2, or Dynavision D2. And basically what this machine is a big whack-a-mole. So you have all these different lights on here. So all these buttons have little red lights behind them, and they'll flash up for a second or two, and you just have to hit them as fast as you can. And so we like using this a lot on the initial day diagnostically to test your reaction time, but also what we can see is it'll give us different measures for each quadrant. And I can say, well, whenever you went down to this bottom right quadrant, you were 0.2 of a second longer. And also we can watch, the D2 isn't as good as some other devices, but we can watch and say, whenever you went up and to the left, you were a lot more dysmetric, or it took you a lot, you kind of hit around the target a lot more, and you didn't really understand where that space is in your environment. And then with looking quickly at different objects, we map out a grid in front of us so that we have a better understanding of where the world is. So think about it like playing Battleship, or there's a grid that you're now having to localize the different quadrants in. And that's the same thing with how our brain works, kind of, where you have this grid in front of us and all these different little areas. And so this this device here we can use diagnostically, but we can also use therapeutically to try and figure out a better understanding of, okay, this is where my bottom left is, this is where my top right is, and just have a better understanding of where the world is relative to you. And then it also has this little screen that you can see right under this lady's hand where it can pop up different things like math problems or word problems or things like that. And we can start incorporating cognitive tasks along with doing this, which makes for a really interesting task. And then from there, we can progress into the gait analysis. So it's not necessarily a piece of technology, but it's definitely something that we look at during the initial exam, where we can watch how you walk and notice all these different things to, again, localize different areas in your brain that aren't working right. Because it's our job to be able to localize these different areas and then provide treatment to get those areas working better so that you can then go live the best life that you can. So something that we're looking at from the get-go is how long is each stride? Do you have one stride that's, or one side of your, one stride that's shorter or longer than the other? And this can happen a lot of times when, let's say I have chronic tight hamstrings on the left, and now my left stride is not as long, or maybe my stance is wider. Why would my stance be wider? Because I feel less balanced. If I don't feel as balanced, I'm going to spread my feet apart so that I get a wider base and I don't teeter as much. I can look and see if maybe I have a foot drop where whenever I bring my foot up, I don't have the strength to actually dorsiflex my foot. And so I don't drag my toe along the ground, I'll pick up my knee higher and then step. That's what we call a steppage gait. Or again, with like having tight or rigid or spastic arms, we can watch the ability for your arms to swing. We can look at how easy it is for you to initiate walking. A lot of times with Parkinsonian patients, they have a really hard time initiating their gait because they have a perceived center of pressure backwards. And that's why they get this hunched over posturing, because they already feel like they're going backwards. So they lean forward to compensate. And in order to initiate your stride, you have to lean forward to lean back. It's the same thing like getting out of a chair. You have to push into the chair to get up out of the chair. And so you can think about is if I already feel like I'm falling backwards and now I have to rock further backwards to initiate my stride, I'm not going to want to do that. So what they'll do is just stand there. And then once they get going, they're pretty good. And then another thing that we'll look at is we'll have you walk down the hallway and we'll have you turn to the left, and then we'll walk back and you have you turn to the right and see what the difference is. And a lot of times what we'll see is we'll have a patient walk down the hallway, she'll turn to the left and she'll be dizzy. And then whenever she comes back and she turns to the right, she's fine. So it's all different things that we look at in order to localize areas of dysfunction, like we've been talking about. And then something else that we add in that I don't think a whole lot of people add in, or that a lot of people really look at outside of the functional neurology realm, at least that I know of, is what we call dual tasking, where that's where I'll have you walk down and I'll have you say, for example, every other month of the year out loud, or every food that you can think of, or every state you can think of, or every animal you can think of, or something like that, to involve a cognitive task. And ideally, whenever we're walking, that task should be automated, and it should be something that you don't really have to use a whole lot of brain energy or brain power to do. It should be something that is completely automated in the subcortical structures and basal ganglionic structures in order to get that task done, so that then you can walk along the sidewalk, be able to monitor your surroundings, watch your kid, make sure your kid doesn't walk in front of the oncoming bus, and also be monitoring the sidewalk signs and all these different things. But what happens a lot of times with concussion is whenever you have a concussion, a lot of these lower brainstem and subcortical structures get damaged, because if you think about concussion, Since the brain is round and it sits inside of a round skull, whenever it hits, you can obviously get blunt force trauma on the cortex or bleeds and things like that. But what we see a lot of is since the brain is round, whenever it hits, it actually rotates. And since it sits on top of a brainstem, when it rotates, it causes a lot of shearing forces and a lot of stretching of axons that are in that area. And that's a lot of the areas responsible for things like your eye movements, for things like feeling that can cause you to feel dizzy, and things that can automate things like gait in your subcortical structures. So whenever your brain starts to go south and these subcortical structures can't regulate your ability to walk anymore, the cortex then has to come down and say, okay, I'm going to take over this task because you're not doing it right anymore. It's just like how I like to think about it is it's like parenting. And so think about it like this. Whenever you have a child, the child needs you for everything, right? They don't know how to do anything on their own, and you have to watch every little thing that they're doing. And then hopefully as they grow up, you're able to give them a little bit more leeway until they eventually, hopefully by, whatever age, they're out of your house and self-sufficient and doing their own thing, and you don't have to really monitor them every day. Well, that's kind of like gait, in the fact that whenever you're born, we learn how to walk eventually, and then over time we learn how to do it well, and it becomes automated in these subcortical structures. And what happens is whenever we hit our head or we bump our noggin and we get these traumatic brain injuries, is these subcortical structures stop working right. So it's like taking your kid that's just moved out of your house and now he started, I don't know, using drugs, and then he now has to move back into your house because he lost his job, and you have to then take care of him. So now it's like the cortex is like the parent that then now has to come and monitor everything that the child is doing now, once again, because the subcortical structures can't do them anymore. Okay. And then while we're doing that, we'll see, do you pulse to one way? Or what we see a lot is whenever we start to cognitively task you with walking, is they'll start hesitating a lot, and with each step they'll like pulse to one side. Or whenever you sway, do you have a appropriate arm response to whenever I fall to my right, I should have a cantilever is what they call it, where it balances me out so that then I come back. Like think about walking on a tightrope and your arms are constantly swinging like that. So that's gait analysis. And then we also have this other piece of eye tracking technology called the Righteye. What the Righteye does is, I think it's really cool specifically for children. I've seen it be very, very beneficial for neurobehavioral disorders where kids, there's like no way that you're going to get these goggles on their face. Well, the cool thing about this one is you don't have to put any goggles on. All they have to do is sit there and look at a screen and go through a progression of different tests. And it basically runs through all of the tests that we did on the Righteye, on the BNG, except for it has another one called circular pursuits. So we can actually see how the eyes go around in a circle. And then what's really cool for children with reading disorders or things like that is there's a test called reading IQ. And basically what that test is it'll pop up a book and watch the patient's eyes as they read each word of the book. And we can see where these patients' eyes are actually going, because a lot of times with these dyslexias type syndromes or things like that, is these patients just can't move their eyes appropriately to each word, and then they have a difficulty reading, and then it'll grade you appropriate to your grade level and your age. So this is the report that it spits out. So it spits out a nice pretty report, which is really cool, and it gives you an overall score. So you can see at the top, it says my IQ. And so it gives you a range on your IQ, what they call IQ, for your age and the experiences that you've gone through. And then over on the right, it tells us what they think to be the area of dysfunction based on the test that they ran. And then it gives you a little bit of score and gives you what percentile you're in for each different test that they ran. You can look at all the graphs and play them and see where your eyes actually went throughout the test. And then eye stability will tell you where your eyes actually were. Because remember we talked about both of your eyes looking at the same target. We can look and see if they're looking at the same target, or one's kind of up, one's kind of down, one's kind of in, one's kind of out. And then at the bottom right, what it'll tell us is based on the testing, what they think that you may have a weakness in a certain eye muscle. So then we can go in and do different exercises to kind of strengthen those muscles and go from there. And then the next one is computerized posturography. This one is really cool piece of technology and definitely one of my favorites, where we basically just graph your balance out. And this is really important because it has a bunch of different tests, but I'll talk about the test that we mainly use in the office. Balance and fall risk is where we can put in your age and it'll basically rate you on how big of a fall risk they think you are for your age based on the different sway that you have. We can look at the different weight distribution that you have from right foot to left foot and see, am I carrying like 75% of my weight on my left foot? We can look at the modified CTSIB, the limits of stability, where and the modified CTSB is what we're going to go over. I think it stands for something test for sensory integration and balance. Limits of stability is where we can see how much you can actually sway. See if you can put more of your center of pressure back and forward and see what your range is. Then we can put your head in different positions and see how that interferes with your balance, and then see what it looks like whenever you stand on a single leg. So this is the report that it's going to spit out for the sensory integration and balance. And basically what we're looking at is a comparison between the three major systems in the body that give you a sense of where you are located in space. So you have proprioception, vision, and vestibular. And these three systems answer the most fundamental question that we can ask, or that the brain asks on a minute-to-minute basis or second-to-second basis, because the brain is constantly wondering, where am I? Humans were designed to move. And so if you think about from a GPS perspective, if I want to move, or if in a GPS, if I want to go to, let's say, if I want to go to the office and I put the destination in for the office, but my GPS can't figure out where my current location is, there's no way that I'm going to get to the office, right? And so the same thing works with the body, where if I want to move, I first have to know where my body is. If I want to be able to reach out and grab this water bottle, I have to obviously know where the water bottle is, but I have to know where my arm is to be able to coordinate the muscles in appropriate action to reach out and grab my water bottle. So these three systems work like this. You have proprioception, which is basically just all the feedback from your muscles and joints telling you where your body is in space. Then you have your vestibular system, which is these canals in your inner ear that tell you where your head is located. And then that compares relative to where your body is. So now I know where my head is relative to my body. And then you have your visual system, which maps out the external environment. And that tells me where the environment is relative to me. And all three of these systems, it's a very redundant system in the fact that all three of these systems need to be saying the same thing in order for you to be balanced and steady and not be dizzy and not be rocky and all of these different things. And so what we see a lot of times in the office and specifically after traumatic brain injury is one of these systems will stop working or not be working as much. So a really common one is the vestibular system and the central connections. that tell your brain where your head is located in space get off, because whenever you hit your head, remember how we talked about you get these shearing forces in the brainstem, and these areas that go into the brainstem from the vestibular system are right there in the center. And if you think about it like wringing out a towel, whenever you wring out a towel, the inner part of that towel is going to be what gets wringed out the most, right? So that's where these connections are at. And so they get damaged a lot of times whenever you hit your head and cause a lot of shearing force. So your ability to know where your head is in space goes down. And so what happens is then after that, the other two systems, proprioceptive and visual, have to upregulate and give in more information to make up for the lack of information for the vestibular system. It's like working in a group project whenever you were in school and you have three people and one person is just a scumbag and doesn't do anything. And so the other two guys have to work a lot harder to make up for the lack of work that he's doing. And so the same thing works here, where now if I have to get more information from my proprioceptive system, what typically happens is my neck gets really tight. And then also I need to rely on more information from my visual system. So now if it's dark or there's not enough light around, then I have really hard time walking. Or if I shut my eyes, I just fall all over the place. And then what's cool about this is it spits out these results, and it'll rate you in a percentile based on your age. And what we can do is during the first part of the week, we'll do the initial test, and then later on in the week, we can rerun the test. And same thing with the VNG, and same thing with all of these tests. And so to tie back into the VNG, what's really cool about having that test is I can show you as a patient, this is what we're seeing. This is how it correlates into what it is that you may be having. And then when we come later in the week and we rerun the test, I can show you, and so I can show you the progress that we've made, or even the lack of progress that we made. And so it comes down to a effort on my part that I have to show up to work every day and be the best that I can for you, because you're going to know not only symptom wise, like I'm not feeling better if I'm not doing my job appropriately, but also you could say, well, you told me that I'm dizzy because of my eye movements here, and on Friday it's time to leave and these eye movements don't look better. So what were you doing all week? And same thing with these balance scores, is we can have a baseline and a post-baseline test, where we can show you, did your balance improve throughout the week or did it not? And so it's just really cool. So it gives you a centimeter readout of how much your sway actually was. And then on this bottom right graph, we can look at the actual direction of your sway and things like that. And then the next piece of technology that we have is the tilt table. And this is really cool for patients that get lightheaded going seated to standing, they get fatigued, they don't have appropriate blood flow regulating to the appropriate places. And the importance of this table and this test is that we only have a certain amount of blood in our body, okay? And that blood can't be everywhere at the same time. So we have to be able to regulate how to shunt blood to appropriate places at certain times. For example, if I stand up, I have to shunt blood to my legs to be able to contract the muscles that are involved with standing up. But I also have to be able to shunt blood to my head to be able to not get lightheaded and dizzy. And a lot of times after concussion or traumatic brain injury, this becomes difficult for patients, and the ability to shunt blood to the appropriate places becomes skewed. And so it's important to be able to not only test your heart rate and blood pressure standing up from laying down actively, but also what we can do on this table is passively elevate you and see if see if you have a different response, and that tells us a little bit different of the area of the area of dysfunction. Because if I stand up, I have to create an efficient or an appropriate motor plan to contract muscles and shunt blood appropriately. But whenever I'm elevating passively, it's all about the baroreceptors in my neck and the baroreceptors on my aortic arch, and being able to sense either more or less blood flow in order to either increase or decrease the heart rate to make up for, if let's say if I'm starting to elevate and I'm feeling less stretch in the baroreceptors, then I'm going to say, okay, the blood's dropping, I need to pump my heart a little bit more, or vice versa. So this test kind of comes into effect with a lot of patients that we see, and it's obviously very therapeutic too, where we can take you throughout the week and raise you up and run you through this this tilt table and do a different combinations of exercises, whether it be stim your tongue or move your arms in different ways, or compress your legs. And we're going to be talking about the autonomic nervous system, and specifically dysautonomia, what that means, and what we kind of do to treat it in the office later in the week. So I'm going to keep this one very superficial again, and then jump into that with a more deeper level talk later in the week. So I hope that you enjoyed this talk. Again, if you have any questions, please be sure to drop them below, and I will get to them as fast as I can. And the next talk that I'll be doing is autonomic nervous system. So I look forward to seeing y'all. Bye.